Thank you very much. It's a real honor for me to talk to you a little bit about efforts at Anthem with regards to the care of seriously ill patients. So I'd like to just identify the issues that we face when trying to think about solutions. We want to talk about a specific program at Anthem called Enhanced Personalized Healthcare. We'd like to talk about our vision for hospice care and then reflect on the barriers that we see in the care of our members with advanced illness and potential models of care to help solve those problems. All of us have seen slides like this. We know the U.S. population is getting older. The number of people aged 65 and greater continues to rise and rise relatively rapidly and is felt to continue to rise for the next 3 decades. As people get older, the number of comorbidities increases. This demonstrates that 60% of people have at least one comorbidity and 20% of people will have 4 or more comorbidities, which complicates the care of members as they become older, as they develop more and more comorbidities and develop serious illness and end of life in their end of life phase. So when we took a look at our members with advanced illness, what we found were that there was fragmented care between primary care providers and specialists. There was limited advanced care planning, inadequate symptom control, aggressive care near the end of life, including the use of the emergency room and the intensive care unit, inpatient hospitalizations, and chemotherapy. And there was a limited hospice utilization. So one program that Anthem has had for the last several years is called the Enhanced Personal Health Care Program. This is a value-based payment program. It involves over 50,000 providers and provides care for 4.5 million members and growing. The clinical goal is improvement in patient-centered care. With regards to palliative care, the goals are to identify high-risk members with daily hotspotter reports so that resources can be shifted to serve those members, and monthly data feeds revealing care gaps and to risk stratify members on a regular basis. In order to qualify for the program, providers have to provide 24/7 access through extended hours and after-hours call coverage. They have to have a dedicated position within their practice that supports participation in the program. Staff regularly participate in collaborative learning sessions. There's use of a disease registry to manage patients with chronic conditions, and they have to be willing to engage in care planning for high-risk populations and to engage in quality and performance measurement. So how's this paid for? Well, there's a significant upfront investment, particularly in human resources. There are transformation teams that go to practices to help them transform from a fee-for-service to a value-based model. And then there are clinical liaisons on the ground working with practices on a regular basis. There's a significant IT bill that's required to allow for data sharing between practices and Anthem. And this is a value-based payment model. Resources are shifted to providers initially to develop necessary infrastructure. And then there are shared savings opportunities, which are first based on quality metrics first, followed by practices meeting savings targets. And there has been a return on investment for Anthem with this program. Hospice care is a program that we are looking to expand. This is an ongoing initiative. It's in its formative stages at this time and not executed at this time. We are planning on changing prognosis requirements from 6 months to 12 months. We're going to allow disease-modifying therapy to continue during hospice care. And it's anticipated there will be quality improvements in parameters such as advanced care planning, hospice use, aggressive care near the end of life with less emergency room and inpatient utilization, as demonstrated by our colleagues at Aetna. And we anticipate this program being financed through potential cost savings. So what are the barriers when we looked at optimizing palliative care for our members? I think it's worth thinking about what the landscape looks like from a patient standpoint. A patient might say, no one has talked to me about palliative care. There are no palliative care clinics in my hometown. My doctor sends me to the emergency room when I'm sick, and I usually have to wait forever. I'm afraid of the cost of treatment, but I don't want my doctor to know this. Maybe he won't give me the best treatment available. And I'm scared. Things seem to be getting worse, and I worry about things all the time. The landscape as seen by a provider might say that his office is busy. I generally have 10 or 15 minutes with a patient and then have to do documentation. Spending extended periods of time with every patient that needs it is not feasible. Or she might say that guidelines say that patients with advanced cancer should be referred to a palliative care team early in their course, but there are no outpatient palliative care teams in my community. And she might say, I'm concerned about referring a patient too early to palliative care. They might lose hope. I know my patients and I know when they're ready for hospice. And from a payer, what we see is advanced directives are being completed by just 26% of American adults. So our members are getting aggressive care that many of them probably don't want. Despite hospice being an established part of the medical ecosystem now for some time, the median length of stay in hospice really hasn't changed recently, and 42% of members use hospice for 14 days or less. Our members are simply not getting the full benefit from hospice. And finally, the issues that our members are dealing with are profound. Medical bills, anticipatory grief, pain and other symptoms, caregiving. Unfortunately, with all these things going on at once, there often is not a central team in place to help patients navigate these waters. So we've looked at different models of care for optimizing palliative care. One is utilizing primary palliative care through primary care providers or specialists such as oncologists or cardiologists. And one of the barriers here is that practitioners require a lot of training. So not only physicians, but the practice staff require significant training. The work itself is very time intensive, which all of you know, and is not conducive to a busy outpatient clinic setting. Developing and staffing a primary palliative care team is resource intensive and not feasible for many practices. All of that being said, there is a consideration for alternative payment models for care coordination if quality metrics are achieved. These are initiatives that are still being evaluated by Anthem. Another model is using community-based specialty palliative care, where you utilize the practitioners that are in your community. The problem, as all of you know, is that there's a scarcity of these practitioners. Most of the palliative care practitioners are dedicated to inpatient consultative work or hospice work. And again, fully funding a comprehensive palliative care team is difficult for hospices and hospitals. We do see this as a potential for accountable care organizations or large healthcare systems entering into a value-based payment model and utilizing their own practitioners. But again, it's not easily generalizable to all practice types. Finally, there are third-party organizations that are implementing palliative care solutions in this country at this time. They have some advantages. They are dedicated to the education of their staff. So all their staff are specialty trained. They have found ways to leverage board-certified palliative medicine physicians. They often provide different options of care, including telehealth, home-based options, or clinic-based options. There is typically 24/7 access to a palliative care team. There is a demonstrated willingness to participate in value-based payment models with both one-sided and two-sided risk. And they've demonstrated the ability to scale palliative care, which is a big development. And they are willing to participate in quality measurements and cost of care measurements. So I think the future at Anthem probably will be a hybrid approach. Large healthcare systems and academic centers and accountable care organizations may be more interested in entering value-based payment models where they are responsible for quality and ultimately cost and utilize their own practitioners. Sizable independent practices may want to develop their own primary palliative care approach and cultivate novel value-based payment models, initially probably based on quality metrics and later on cost. And finally, third-party organizations may provide a scalable outpatient solution across markets, across geographic regions, and across different sized medical practices with reimbursement tied to value-based payment models. So thank you very much.